Alrighty, well, why don't we go ahead and get started? Thank you so much for being here today. My name is Rich Botner. I'm an assistant professor of internal medicine at Dell Medical School and have been your host for this webinar series, which I am sad to say is coming to a close today. This is part 5, where we will focus on an area that is not necessarily directly clinically related, but in many ways provides so many barriers to us being able to provide evidence-based clinical care to our patients, and that is stigma. So I'm really excited that you're joining this conversation today, and let's get started. So we have nothing to disclose. And today we'll talk about 3 primary things. We'll talk about defining stigma and its many different forms that we see within healthcare. We will talk about the impact of stigma on our ability to deliver evidence-based care. And then we'll talk about different opportunities to offer hospital-based opioid use disorder treatment and how stigma can sometimes create barriers to doing that. And as we've been talking about for this entire webinar series, the goal of all of these discussions and trainings is to increase access to evidence-based care for substance use disorders during acute hospitalization. And we've been doing this work at DelMed for the last 4 years. And as we have shared our work with different people across the country, one of the questions that we often get is, why isn't hospital-based treatment of opioid use disorder or substance use disorders the standard of care everywhere? And I've come to the conclusion that there are sort of 3 main reasons for this. One is we have not done a great job as a healthcare training system to make sure that when people graduate from their various training programs, whether they are physicians or medical or PAs or nurses or pharmacists or social workers, that they have the tools on their tool belt that they need in order to go forth and treat people with substance use disorders. The second is that there's a large burden of systems-based practice. There's a lot to know in terms of the legislative environment, the regulatory environment, the reimbursement environment, and it's all very complex and it changes quite a bit depending on what part of the country that you're in. So that really complicates the picture. And the third, and the one that we're going to focus on today, is stigma. And I would argue that stigma actually largely informs part 1 and part 2, right? So the reason we don't have more robust education mechanisms is because of stigma. And the reason why we have such complicated legislative and regulatory environments around substance use disorders is because of stigma. So stigma drives so much of the barriers to care for people with SUD. And so at most institutions, and hospitals are no exception, this all sort of collides and ends up with a lot of people kind of going, ugh, I don't know what to do. I don't know what to do with all of this. I don't know how to move forward. Isn't this really just a psychiatrist's problem? And so we're just going to sort of ignore it. And we're at a point now in our country within our drug epidemic, not just with opioids, but with so many other substances, that this is a all hands on deck kind of situation. And we really are no longer in a position to sort of turf this to behavioral health specialists alone. All of us have a role to play. And if we can start chipping away, eliminating stigma, we can really provide so much better care for people with substance use. And if we're going to talk about stigma, we have to have kind of a shared definition of what stigma is. And the original term for stigma, the root of stigma, was this Greek word known as stazine. And a stazine was a mark burned onto the skin of slaves to signify their low place in social hierarchy during ancient times. And even though this was thousands of years ago, you could argue that we still do a form of this today. We mark patients. We mark patients in the words that we use to describe them to our other healthcare colleagues. We mark them in the terms that we document in the medical record. We find markings on physical exam, for example, for someone who has a history of intravenous drug use. And so these marks exist even today. And Goffman, who's one of the main sociologists that has studied stigma, one of the originals back in the 1960s, describe this as kind of a two-part process. And I'll put two definitions on the screen for you here. And I won't read these to you, but the big takeaway here is that the marking is only the first part. There's a second part, which is the subsequent devaluing of the person, of making them not equal humans, of making them discounted and tainted. So we mark them, we label them, we identify them, and then we subsequently marginalize them. And that really is the core of what stigma is. Now, there's often terms that are sort of thrown around when we talk about stigma that are sort of interrelated to stigma, and I kind of want to tease those out here. And those include stereotypes, prejudices, and discrimination. And I view these as sort of a linear type of process. You know, stereotypes are beliefs that we have about another group of people that are, you know, inherently bad, right? There are rarely good examples of stereotypes. So stereotypes are generally negative, and they are generally a way of describing another group of people in a way that sort of reduces them. And so just an example of stereotyping might be that, you know, people who use drugs are bad, right? That's just sort of a very simple example of a stereotype. It's not a belief or a stereotype that I hold, but it is a stereotype that certainly exists within our society. Prejudices are feelings that we generate as a result of those beliefs. So as a result of believing that a person who uses a substance is a bad person, I may start to generate feelings of hatred or disgust or fear around those individuals. And once those feelings start to permeate inside oneself, what often results is discrimination and marginalization. And that is when we provide disparate systems of care for people based on these prejudices, based on these feelings. And I think we can all agree that people with substance use disorders are at particularly high risk of being discriminated against, not just within our healthcare system, but decreased access to housing and decreased access to employment. And so lots and lots of different ways that people with a history of drug use are discriminated from in our society. And there's different types of stigma. When you came to this talk today, you were probably thinking that we were going to be talking primarily around social stigma. And I think of social stigma as the kind of stigma that permeates when we have discussions about people with a history of substance use amongst our colleagues or our family or our friends, or if we're sort of walking down the street and we see someone who we identify as a person who may have a history of using drugs, the sort of narrative that ends up often being attached to those interactions, the narrative that we see in the media, the narrative that we see in the movies. Those are all examples of social stigma. It's how we feel about this group in sort of more social settings. But there's two other forms of stigma that are really important to appreciate. One is structural stigma. And structural stigma is rooted in policy. And I use the term policy very broadly. It could be policy at the institutional level, right? All of the organizations that we work in. It could also be policy at the local level within the city. It could be state policy. It could be federal policy. And just one example that has entered into my life in the last couple of weeks in a very large way was the changing of the X-waiver regulations around prescribing buprenorphine for opioid use disorder treatment, where previously you needed to have 8 hours of extra training as a physician or 24 hours of extra training as a physician assistant or advanced practice nurse to prescribe this medication that is extraordinarily safe and evidence-based. And of course, the ironic part is that you do not need any special extra training to prescribe, oxycodone or hydrocodone, so forth and so on. And so that's a prime example of a structural stigma of creating disparate care, creating barriers to care for people with a history of opioid use disorder, because we know that there's a huge gap in the number of prescribers in the country who are able to prescribe this medication, this buprenorphine. So that's a really good example of structural stigma in my work. And then there's a third example of stigma, which is self-stigma. And self-stigma is one that we don't talk about enough and that we don't label enough or understand enough, but is an exceptionally important one. And it has to do with the stigma that a person who uses substances internalizes and feels themselves. And this is also sort of a process. And, generally speaking, it has to do with a society creating a norm around a group of people. So a society, again, using the example that, people who use drugs are bad. And as that becomes the norm, people who use drugs start to identify themselves as individuals who use drugs. And that ultimately, if society is saying and labeling, and the norm is that people who use drugs are bad, then people who use drugs apply that to themselves. And then they internalize that they must, in fact, be bad. They must, if society says people who use drugs are bad, then I, as a person who uses drugs, I must be bad as well. And that causes harm because it leads to a very well documented sociological phenomenon called why even try? And where I work in a safety net hospital where patients and people with substance use disorders are not really engaged in outpatient care up until that sort of life-threatening condition forces them to go to the hospital, this is what we see. We see this profound sense of hopelessness, this profound sense of shame that people with substance use have faced. And this happens over time. This doesn't happen overnight. This happens over days to weeks to months to years of having just so many barriers placed against them. And so they end up with just so many challenges that they essentially give up, right? So these are the kinds of stigma that we're talking about. And stigma is a really complicated topic. Our friends to the north in Canada came up with a whole framework around this. They spent over a year studying at the national level, a very well-funded approach to looking at stigma in Canada. And they came up with sort of four main buckets of how they were going to approach reducing stigma. One is that they knew they had to figure out how to describe it. What does stigma look like? What does stigma feel like? They knew they had to figure out how it impacted care. How does it get in the way of people who use substances obtaining the care that they need? What are the tension points and the contributing factors of that stigma to the society? And I will tell you again, stigma is complicated. So this is not all on the part of prescribers or providers, right? Stigma is shared. The way that stigma permeates throughout our society, that is shared by all members of society, right? Healthcare is not exempt from that though. So it certainly exists within healthcare settings as well. And then, of course, the final piece here is how do we get rid of it? How do we tackle it? What are some of the promising approaches to do so? Now, I'm not going to read all of the rest of this to you. This is really more of a reference, but this is just an example of showing how complicated the problem is and how complicated it can often be to come up with a solution. This is what Canada did. There has not been a formal process like this in the United States. There's been some, obviously some articles written about stigma, so forth and so on, but we have not come up yet with a sort of systematic approach on how we reduce and ultimately eliminate stigma. Now, I want to make a note here that, patients, no matter whether they are patients who use substances or otherwise, patients have a right to autonomy. That's one of the main sort of foundational components of our healthcare system and how we deliver care in the United States, that patients are allowed to retain their autonomy no matter what, even if they have a history of using substances. And so we have to respect the degree to which patients want to be labeled, or the terms that we use to describe them. So 250 plus patients in Massachusetts in this one study responded, and they basically, the most common term that they said they wanted to be referred to as was addict, and the least common was junkie. Now, to be clear, we, healthcare community, healthcare providers, should not be using the term addict. That is considered part of our no-no language that we'll talk about later. But it's okay for patients to refer to themselves in any way that they see appropriate or that they see fit. But when it comes to healthcare providers and when it comes to how people who use drugs want to be referred to by healthcare providers, what you're seeing here are terms that are patient first and recovery centered. So a person who uses drugs, a person with a heroin addiction, so that the patient comes first, the diagnosis comes second to that. And we know that stigma manifests into clinical care in a number of different ways. One, we know that on average, as an aggregate, health professionals have a negative attitude towards people with substance use disorders. When stigmatizing language appears in the medical record, patients with a history of substance use disorder don't get adequate treatment of their pain when they're in the hospital. And we know from a really great longitudinal study that medical students have a certain degree of stigma. When they go into their residency, that stigma increases. And then when they graduate residency and go on to being attending physicians, that stigma continues to increase over time. We expect that medical knowledge improves over time, no matter what discipline you're in, whether you're a pharmacist or a social worker, a nurse, a physician, et cetera, that the knowledge of the way you practice and deliver care gets better over time. And we should have the same expectation around stigma. That stigma should decrease over time. But in fact, our system has created so many barriers and so many disparate ways of approaching care that stigma actually increases over time. And that, as you can imagine, is a major problem. Lots of examples of how stigma directly affects our ability to care for people with a history of opioid use disorder. There's a study about people who use intravenous drugs who have end-stage liver disease and cirrhosis from hepatitis C, who need liver transplant, who are engaged in a buprenorphine program. They are sometimes turned away. They are told, sorry, we do not provide care for you because you are engaged in this pharmacotherapy program. And without stopping, buprenorphine, we cannot provide surgery, this life-saving surgery of a liver transplant. We've seen many examples where patients who are in need of a valve repair for infective endocarditis are not able to access that because cardiothoracic surgeons refuse to perform the surgery because of their history of intravenous drug use. And we know that the extent to which there is stigmatization of substance use in pregnancy, it is massive. And that this stigma of people who are pregnant and who use substances creates so many barriers to care. It's often talked about as being doubly stigmatized because you're stigmatizing the pregnant mom and the unborn child. So these are just some examples of how this permeates into our communities and into our practices. I'm sure we all have our own, and of course there's many more in the literature as well. And part of the challenge here is that we view substance use as a moral failing. It's often treated as a moral failing. We think to ourselves, why don't you just stop using? But in reality, we know that substance use is driven by so many genetic and environmental factors, and that there are rates of recurrence or relapse that's actually very similar to other chronic diseases. And the example I always use here is diabetes. If a patient presents to the hospital and they have a blood sugar of 450, we have a robust system of care that's going to help that patient. We will pay for insulin. We will provide insulin counseling. We will make sure that patient has a follow-up appointment. We have a nurse that calls that patient the next day to make sure that they have good glucose control. And that same type of system does not exist for substance use, even though those rates of recurrence are actually very similar. And that system of care that we provide for people with diabetes, we do that all the time. We do that all the time, even if it's that patient's second or third or fourth admission to the hospital for high blood sugar in the last 2 months or whatever. So clearly there is a pattern of not providing the same degree of care to all people with chronic medical conditions. And at the end of the day, that is exactly what substance use is. It is a chronic medical condition. I'll direct you to this definition from the American Society of Addiction Medicine. I won't read the whole thing to you, but I think it's important to tease out the very first part here, which is that addiction is a treatable chronic medical disease. Treatable chronic medical disease. And I think that really just says so much about why our system of care is a bit backwards when it comes to people with substance use disorders. Even knowing that there's things that we can do, that addiction and substance use is a chronic medical disease that has treatments that we often just choose not to provide in our healthcare system. And it's important to kind of think a little bit about what does the general public think about substance use disorders, right? Because these are our colleagues, our family members, our friends in the community. And as you can imagine, it's not so great. They think of people with SUDs as being, reckless and unreliable and undeserving, threatening, hopeless, blameworthy. And people with substance use disorders are commonly seen as being sort of intimately linked to HIV and hepatitis C and driving under the influence. And actually, in a survey of 1,000 adults that are, from across the United States, 75% felt that patients with opioid use disorder were actually themselves to blame. And so this informs, what we see happening in the media and in the movies, and also what happens in policy. And I wish we had all the time in the world to talk about drug policy and how drug policy has created so many challenges for people with substance use disorders to access help. And there's so much to talk about here, but in the interest of time, I'm just going to give you one layer of this that is really important to appreciate. And that has to do with the structural racism that exists within our system of care for people with substance use disorder. So what you're seeing on the screen now is US drug arrest rates over a period of over 20 years. And probably not surprising to anyone, the arrest rates in the Black community related to drug possession is far higher than what you see in white communities. And this stems back to the 1970s war on drugs. Back then it was cocaine, and now it is heroin, but it has created massive disparities among individuals of racial minority groups. And just to sort of make this way more simple than it actually is, back in the 1970s, the criminal charges and the risk for incarceration was based on the weight of the cocaine in your possession. And so the heavier the cocaine, the longer the sentence. And the rock cocaine was predominantly in Black and brown communities, and powder cocaine was predominantly in white communities. And you could imagine that the rock cocaine was much heavier and the powder cocaine was much lighter. And so what you ended up having was huge disparities in rates of incarceration between Black and brown communities and white communities. And those disparities continue today, 50 plus years later, still mass incarceration, still drug policies that many argue are ineffective. And just to give you an example of how this structural racism continues today, if you're white, you're 35 times more likely to receive treatment, pharmacotherapy, treatment for opioid use disorder than if you are Black. 35 times more likely, and this is in 2019 was when this study came out. So this is today, and so there's a lot of work that needs to be done around drug policy, and stigma is at the root of drug policy, and the people who make the policy, right? Our policy makers, those who are elected and those who are appointed, they are, for the most part, members of general society. So if you think about the slide before this, and I sort of shared with you a little bit about how people in general society feel about substances, that permeates into our policy circles and creates so many barriers for all people in our country, in particular minority communities. So, what do hospitals have to do with all of this? Hospitals are critical access points. I think we've been making over the last several sessions the case that hospitals are critical access points. and great opportunities to provide OUD screening, management, treatment, harm reduction. All of these things can be so much better addressed in hospitals across the country than they are today. But one of the barriers that we see is this sociologic concept called not in my backyard, or NIMBY. And NIMBY is a really important sociological principle when we talk about stigma and we talk about barriers. Not in my backyard, or NIMBY, can probably best be explained through what happened in West Virginia. So in West Virginia, they had, immense burden of opioid overdoses and overdose deaths. And, it came to a point where almost everyone knew someone who had been adversely affected by opioids, either had opioid use disorder or knew somebody who had died of opioid use disorder. And so they wanted to expand access to OUD treatment. They went to the citizens, the state, and they said, look, we're gonna pass a tax bill, a new tax law. We're gonna raise taxes so that we can expand treatment. And people supported this left and right. People really felt like as a state, they needed to do more to address OUD treatment. And so it passed with overwhelming majority. But then it came time to actually do the planning. Where are we going to put the treatment centers? And the same people who voted in favor of expanding access to treatment were the same people who then said, not in my neighborhood, please. I don't want that anywhere near my house. I don't want it anywhere near my kid's school, so forth and so on, despite there being abundant evidence that when you expand access to treatment, there is actually no statistically significant increase in crime that occurs around those treatment centers. This is a great example of not in my backyard. People who support increasing access to treatment, but not in their backyard, not near where they live or work or play. And the same thing happens in our healthcare system, because you have hospital administrator who says, I support treatment. We need to have more treatment in our society for people with opioid use disorder. And I think we're at a point now in our country where, most people who are sort of in the know support the idea of increasing access to treatment. But what you'll hear is, not in my backyard, not in my hospital, right? Not in my primary care clinic, not on my labor and delivery unit, not as part of my general surgery service, not in my emergency department. I support it. This is a great idea. We should absolutely increase access to treatment, but not here. And the message that has to be sort of responded to with NIMBY is, if not you, then who, right? If not now, then when? And it's particularly relevant when, as we talked about in the previous sessions, we had over 80,000 overdose deaths in our country in the 12 months prior to May of 2020, right? So now is the time. This is an all hands on deck response that is needed. There is no room for NIMBY. NIMBY in the healthcare setting implies that this work is best and only done by behavioral health workers, by psychiatrists, by psychologists, by licensed clinical social workers. And if I had it my way, we would have an addiction psychiatrist for every single patient in this country that needed it, or an addiction medicine physician, or an addiction medicine APN or PA. We would have LCSWs, and we would have all of the appropriate alphabet soups for every patient that needed it. But we know that's not the case. We know that the dedicated addiction workforce is extremely small compared to the need. And we know that we get the best outcomes when we integrate care, right? SUD is a chronic medical diagnosis. There's no reason, other than stigma and education and the system stuff that I talked about earlier, that to a certain extent, that cannot be handled in primary care. Now, just like any other diagnosis, as your diagnosis progresses, or if it regresses a little bit, and as a primary care person, you need extra help, you call a specialist, right? You refer your patient to a cardiologist, an endocrinologist, so forth and so on. That's the way our system for substance use disorders should operate, but it doesn't. The way it operates now is you essentially can only go to the specialist for the most part. And if you're a patient who doesn't have means, that's almost a conversation non-starter, right? So this idea of NIMBY, there is simply no room for it in our current healthcare environment. So I'm kind of making the case here that, hospitals need to do this. And we've talked a little bit about this previously, but I want to sort of recenter us around some of this data because it's really important. Most hospitals say, well, we do something already. We do something. We provide withdrawal management, so we're good. And we know that when all we do is provide withdrawal management in the hospital setting, 80% of patients are back to using opioids at 30 days after hospitalization. That's what happens when we don't provide any sort of long-term treatment plans. And these conversations in hospitals often center around overdose, right? They often center around overdose and withdrawal. So a patient is transported by EMS to the ER after a revival in the community, and they had an overdose, and now we sort of mitigate that in the ER, and then most of the time they were discharged from the ER. Sometimes they have to be admitted for they have to be intubated, or they have to be on a naloxone drip or whatever it is. That's the narrative that we often talk about. But when it comes to hospitals, there are so many other reasons that patients present as a result of opioid use disorder than just sort of this average picture of a patient who overdosed. And that includes sexually transmitted infections as a result of drug use, hepatitis C and all of the sequelae of that happens as a result of intravenous drug use, infective endocarditis, epidural spinal abscesses, skin and soft tissue infections, and cellulitis. So the conversation, the narrative that is often shared in boardrooms, for example, around the overdosed patient who comes to the ER, does that happen? Absolutely. But are there many, many, many other reasons that patients present to the hospital and get admitted to the hospital and have complex, prolonged, expensive hospitalizations? Absolutely. Absolutely. So we know that hospitalization is a reachable moment. We know up to 30% of patients leave the hospital against medical advice or self-discharge because of inadequate treatment of withdrawal, fear of mistreatment, opioid cravings. And as we've discussed before, this is one of the landmark studies about hospital-based treatment of OUD, that when patients were randomized to a group that only got sort of a resource packet, 12% of those patients made it to treatment after discharge. And that's compared to 72% of patients who were actually initiated on buprenorphine therapy during hospitalization. I mean, that's just a massive, massive difference. We know around readmissions, patients with SUDs are more likely to be readmitted within 30 days, even when we adjust it for age and sex and depression, insurance and housing and Charlson score, which is our comorbidity score. So even when you adjust for all that, patients with SUDs are almost 2 times more likely to be readmitted, yet patients who are engaged in buprenorphine treatment have a 53% reduction in 30-day hospital readmission. And then, of course, there's the quadruple aim. And the quadruple aim has a lot to do with care team well-being. And so much of the stigma that we see that occurs in hospital systems, it comes from us, it comes from the care team. So if we give people tools in their tool belt, and as a result, improve the way that we deliver care and we change the way that we have conversations, that as well begins to decrease stigma. So you know about our program already, right? We had this sort of problem. How do we treat hospitalized patients without an academic, without a addiction medicine service? And we do it by empowering our team. So you've already heard me talk a little bit about the B team in one of our previous sessions. But what we should talk about is how that has informed our ability to reduce stigma. And so even though our initial focus was on medication, right? You will recall that our goal was to start this as a quality improvement project to improve access to buprenorphine during hospitalization. That was really it. But what we noticed as we went on doing this work was that we were actually reducing stigma. And we were doing that because we made it an educational priority of the institution to train people about opioid and substance use disorders. We had priority messaging about this from not just our team, but from other leaders in the institution. We facilitated kind of challenging conversations about substance use that weren't happening before in the institution. And these conversations were happening, in lecture rooms with residents. They were happening in department meetings, not just, physician and prescriber department meetings, but nursing unit meetings and social work and pharmacy department meetings. We went to the boardroom and presented to our medical executive committee. We presented to the president's council. We presented to the philanthropic group of the hospital, the community donors, just so that they knew that there was something exciting going on for a patient population that had been ignored for a very long time. And every time we had one of these discussions, one of these conversations, we were having them around the medication and why the medication was important. But of course, what we learned as we went on in our process was that this is all about so much more than just buprenorphine. It's about changing culture, changing a system, changing our approach to care. And we ultimately did that by role modeling, right? Just 3 or 4 of us to start, and then kind of snowballed from there, well over a dozen now. Role modeling appropriate evidence-based care for people with substance use disorders. And so the bottom line really is that we recognize today that the hospital is a critical access point, and that addressing opioid use disorder is a critical component of what we do, and it's our standard of care. If you're admitted to our hospital and you have a history of opioid use disorder, you will receive evidence-based care that includes buprenorphine, it includes naloxone at discharge, it includes being connected to outpatient resources at discharge as well. So what can you do around stigma today? I'm going to leave you with some resources here. So one is using person-first recovery-centered language. 2 is identifying and eliminating structural barriers. And then 3 has to do with changing the narrative by changing or refocusing people with substance use disorders, not as problems, but actually focusing on solutions. So in terms of appropriate language, these are a list of terms that you should use versus a list of terms that you should not use. This is low-hanging fruit. This is easy. Remove the terms from your memory and your vocabulary that are on the left and replace them with the words that are on the right. This is sort of a basic chart. There's some more advanced ones that you can Google, appropriate language for substance use disorders. But language is critically important and something that we can all change, today. 2 is thinking more about structural barriers that exist within your organizations. And structural barriers are policies, they're institutional actions that restrict opportunities. And there's a lot of different examples of this. It could be whether or not your hospital initiates buprenorphine or methadone or extended release naltrexone, or you are prohibited from doing that by policy. It could be restrictions in your formulary. It could be lack of care coordination. It could be a misunderstanding of the regulatory environment in thinking that you need to have an X waiver in order to order buprenorphine as part of hospitalization. We know, in fact, that's not the case. You need it to prescribe buprenorphine at discharge for dispensing at a community pharmacy, but you do not need it to order it as part of hospitalization. Any provider with ordering privileges can do exactly that. And I think this is probably the biggest takeaway of this whole talk, is that we need to change the narrative. We need to shift how we talk about people with a history of opioid use disorder. And the challenge is that the narratives that we hear now, whether it is in the media, whether it's in the movies, even if it's within our own circles, our own healthcare circles, they're generally negative. There was a really good peer-reviewed editorial by a group of Yale first-year medical students a few weeks ago, talking about how in the first step exam, the USMLE step 1, there is tons of stigmatizing language in the exam questions around people with substance use disorders. There's also a great op-ed in Stat News recently, and the title of it was "People Who Use Drugs Do Go On to Do Good Things," right? And that's so true. It's so true. We have a way of labeling people with a history of substance use disorder in our society as being permanently damaged, permanently tainted. And of course, that is just not the case. So the picture you see on your screen here was drawn for us by the very first patient we ever started on buprenorphine at our hospital. And this was a patient who was very agitated. He was about to be administratively discharged for using heroin while in the hospital, which you can imagine is a high risk activity that the hospital was not going to tolerate. And so they were going to discharge this patient who had been hospitalized for his third episode of endocarditis in the previous couple of months. And he was very upset about this, and he was sort of screaming about how nobody was wanting to help him, and nobody was listening to him, that all anybody wanted to do was talk about his heart condition, which was his endocarditis. And so the nurse had heard that we were starting this effort to initiate buprenorphine in the hospital. And so even though we hadn't started it yet, the nurse called me and said, "Hey, this patient's really upset and I really want to help him. Is there anything we can do?" And so I called our chief medical officer and I said, "We're not necessarily ready to do this yet, but if this patient's agreeable, can we give him another chance?" And our CMO was agreeable to that. And so, and this was back, by the way, when we didn't fully appreciate how truly straightforward and safe and not complicated it is to start people on buprenorphine. So that's why we were a little bit hesitant. Anyway, we met with this patient. I sat with him at his bedside, kind of eye level, and we sort of talked it out. And he repeated that same thing to me, that nobody cares about me. All people care about is my heart and the policy, but nobody cares about me as a person. All they're looking at is my heart, and then whatever these crazy policies are, or what he saw as crazy policies. And so we kind of talked it out. I said, "Look, this is the situation," and I explained what buprenorphine was and this and that, and he said, "Okay, I will try it." And so we started him on buprenorphine. We had a whole just-in-time training with our nursing staff, and I went home for the evening and called later that night and checked in on him, and things were going okay. He had been more calm, and he had gotten his second dose of buprenorphine, was doing really well. And then the next day I came in and I heard singing at the end of the hallway. What is that? And so I went down to his room, and he was sitting on we have these couches in the patient rooms, and they have these big picture windows that oversee downtown Austin. And he was blasting Led Zeppelin, and he was playing the air guitar and singing Led Zeppelin on the couch, looking out the window down on the state capital of Austin. Or state capital of Texas in Austin. And so it was really, really amazing to see this transformation. And so he ended up staying with us for 6 weeks for endocarditis, did amazing, built incredible relationships with all of the members of the clinical team. And when it got closer to his discharge, he said, I'm going to draw you a picture. And he drew this, and he was describing what his hospitalization and his life was like to him before and after being hospitalized at our hospital. And so on the bottom left, you see him, in despair. This is him sort of growing up on East 3rd Street in Austin, which was sort of a rough area at the time. This is someone who's been in and out of incarceration and drug charges and so forth. And he, if you go counterclockwise, he drew the mass because he would say that, using drugs, you never knew what kind of person you were going to turn into. So it was sort of like the mass of addiction. And then every time you use, you don't know if your substances were maybe laced with something. So it was like rolling the die. And then all the time that had ticked away from all the years of his substance use, but then the light, beaming through this darkness, the clouds of his addiction, was meeting our team. It was being hospitalized at our institution, where he felt that he was treated like a whole person. He was given a second chance, even though he used heroin in the hospital, which is, I tell this story, and especially administrators that I've met from across the country. They just can't believe that we gave someone like this a second chance. But that's the debt that we as a medical community owe this patient population for having marginalized them so much as a community, as a whole. And so he so appreciated it. He went on, completed his hospitalization, continued in treatment, so forth. So this is one example, and this was actually the story that really allowed us to start gaining traction in our hospital. As more nurses heard this story, as more residents heard this story, as more social workers heard this story, people wanted to have similar outcomes for their patients. And so, we all have positive stories to share. I can assure you that at the same time this story happened, there was probably at least one other story in the hospital of somebody with a history of substance use that maybe wasn't going so well. And we chose to share and to amplify and echo this story as much as possible, even today, 3 years later, because the story resonates. And you all have stories like this. And so the challenge that I will give to you to walk away from today is find those positive stories within your own institutions and then amplify those and echo those, because that is what will make a difference. Is if we change this narrative and we start to treat people with substance use disorders as patients, as humans, and not as problems. As I've mentioned to you earlier, we created what are called the Reset modules through a grant from the Association of American Medical Colleges. You can get them for free at resetstigma.org. These are not sort of death by PowerPoint. They have videos of people with lived experience. They have animations. They have interactive learning activities. There's a pre and a post test. There's all sorts of stuff. It is not death by PowerPoint. And you get a free CME. So strongly recommend checking this out. You can share it with all of your colleagues at will. It is completely free, no strings attached. So check it out. It's about an hour and a half or so. It's basically this lecture is sort of a primer to the module. So if you found this lecture helpful, you should definitely check out the modules. Also, Dell Medical School has a partnership with Shatterproof. Shatterproof is the largest nonprofit in the country to focus on substance use stigma and eliminating that stigma. And so we have a partnership specifically helping Shatterproof navigate the healthcare space. They do a lot of really great work and they have a really wonderful network. So you can and should check them out as well. And then finally, we have our office hours that will continue every month. And we are launching our ECHO Community of Practice on June 17th, which is super exciting. That is an opportunity to build your network of collaborators from across the entire state in sort of an academic environment that's all virtual. It's a little bit more, or it's a lot more interactive than a webinar. And so I definitely encourage you to check that out. You can get more information on our website. There you go, June 17th, 12 to 1, and it will be recurring. It's the third Thursday of each month. All right, I'm going to leave this on the screen for a minute so you can get your QR code. And let me pause there and see if there's any questions today. Let me activate everybody. You're free to unmute, or you can use the chat box or the Q&A box, whatever is most user-friendly to you. And if there are no questions, that is our content for today. I hope it was helpful. But yeah, happy to take any and all questions. Going once, going twice. Alrighty, we all have our contact information, but just in case, this is an email address. You can reach me on Twitter. Please do absolutely anytime we can be of any assistance, feel free to reach out, and we look forward to seeing you as part of our Echo series coming soon, June 17th. Have a great day.